introduce Jeremy Cannon. He's actually associate professor of surgery at the University of Pennsylvania, who's a colonel in the Air Force and the reserves, being assigned at the current time to Travis Air Force Base. And so he's nice enough to take some time out from his reserve deployment and come here and talk to us. He has an interesting background, one that I can relate to. He went to Air Force Academy in Colorado Springs and then graduated in biochemistry. Got his MD at Harvard School of Medicine, and during the middle of his residency at Beth Israel Hospital, took time off to get a master's in science at MIT in engineering. Biomedical engineer background myself, so I appreciate the engineering background with that. So a combination of the sciences and engineering and a Harvard and Boston trained person. Deployed, I believe, 3 times, once to Iraq, twice to Afghanistan, and now is active in the research arm at Travis Air Force Base and still in the reserve. So Jeremy, welcome, nice to have you with us, and thanks for the presentation.
Well, thank you for that very generous introduction. It's really a privilege and an honor to be here among friends and colleagues. I bring warm greetings from Pat Riley and Bill Schwab. Just got so many mutual connections here. Of course, they're sort of dealing with the fallout from the Eagles and sort of trying to plug all the holes and deal with the multi-casualty events from the awnings falling down and people flipping cars over and whatnot. So in some ways, I'm a little glad that I'm here. So I have no disclosures, but I am in uniform, so the Air Force usually wants very little, if anything, to do with me, and they don't claim any of what I'm about to say. Everything I am going to present on is FDA approved, and I look forward to having hopefully a good discussion about whole blood. I'll be mindful of the time and really sort of zip through my slides here so we can have some conversation at the end. None of this would be possible without some really strong advocates and great allies in the blood banking world. So Franz Fote, Anna Moran are pathologists and blood bankers, and Roxanne Reynolds is the director of our blood bank. John Gallagher is our trauma program manager and has really done a lot of the education and background work on this with me to get this whole blood program that we've just started at Penn up off the ground. Our blood supplier in Philadelphia is the Red Cross, and we've got a great advocate and a colleague at the Red Cross there, Dr. Bourget. And then really the idea that we could do this came from Cooper. We've got good friends and colleagues, John Chavanez, John Porter, and then their blood banker, Charlene, has really just been a very important advocate for using whole blood at Cooper, and that has really spilled over to our program at Penn. And last but not least, this research group, this collaboration called Thor, led by Phil Spinella, Don Jenkins, and then a blood bank representative from Pittsburgh, Mark Yeaser, really has been inspirational. And you'll see at the very end that they've had a tremendous breakthrough. Sort of the punchline that I won't spill comes at the end. And I hope that whole blood will be more readily available to centers across the country. Much of what I'm going to talk about was forged in the Crucible of War. This is one of my favorite quotes from Dr. Schwab that really captures the essence of what going to war and being a trauma surgeon is all about. It's a laboratory of nightmares, to be sure, but there have been important advances. You'll see with regards to whole blood, though, we've really just come full circle, and I'm going to highlight some of that as I talk through this topic. To get the lay of the land, how big of a problem is hemorrhage? It's a huge problem. This is why our patients are dying, and these are patients that have potentially preventable death. I would commend these 2 manuscripts to you by Brian Eastridge. This one is the pre-hospital lay of the land, and you see that pre-hospital hemorrhage is a major cause of potentially preventable death. There were about 24% of the deaths were deemed potentially preventable, and the vast majority of those were patients bleeding to death. And you can see the story is the same in the hospital. So unfortunately, these individuals make it to the hospital only then to bleed out and die from hemorrhage. So if you add all that up, that's over 1,000 potentially preventable deaths from bleeding alone. So really a pretty sobering statistic. Now, I'm a huge Pats fan. It's a little difficult being a Patriots fan in Philly, but it was not difficult to find a grouchy Belichick photo after Sunday's performance. So he would not be happy about these statistics for sure. But the good news is we've done a lot to sort of address this. Really concurrently, as these statistics were becoming known, we were doing things like increasing the ratio of plasma and platelets to red cells. This is the Borgman paper, and I'll talk briefly about this later in the talk. This is Phil Spinella's whole blood study. Now this is warm, fresh, type-specific whole blood. So it's really the ideal product, taken directly from the donor in a blood bag and almost directly into the operating room. And you'll see the results from this were really tremendous. And then I'd commend this article to you, very recently published in JAMA. Stacy Shackelford and her colleagues assembled some really impressive data to demonstrate that, not surprisingly, administering these blood products early on in the pre-hospital environment really does impact mortality. So what does that add up to? Well, over the course of about a decade, you can see that although the injury severity of these combat wounds was going up, the case fatality rate was thankfully decreasing. But do these principles and do these injuries actually occur in a civilian environment? Do the principles apply at a place like Penn or UC Davis or in the pre-hospital environment? And that's the question we really hope to address. So I was the chief of trauma in San Antonio at SAMC. If you're in the Army, you'd still call it BAMC, so it's still a little inter-service rivalry there, but nonetheless, we had a great collaboration and took care of a lot of very injured individuals, both civilian and military. And now I would ask you, you think this is a civilian patient or a combat casualty? And similarly, what about this? So large open chest wound with lung herniating out through the chest wall. Both of these patients are civilian patients, and they've got massive injuries, lots of bleeding. So really, I would advocate for applying these combat casualty lessons learned even in a civilian environment, selectively. But in cases like this, it really makes a lot of sense. What about the demographics and the data? Is bleeding the #1 cause of death and potentially preventable death in the civilian environment too? Well, there are two, again, really important papers I would commend to you. This one from the group at Ryder Trauma Center in Miami. They looked at pre-hospital potentially preventable death. They looked at a total of 512 deaths and determined that 146 of those were potentially preventable. Percentage sounds pretty familiar, that same roughly percentage that Brian Eastridge found. And those were 146 potentially survivable cases. That's in one U.S. county in 1 year. So this is really the submerged part of that iceberg that I think we really need to get a handle on. Now, there's Grumpy Belichick again. What were the causes of death? If you distill it down to what caused the death in these individuals, there were some airway issues, some TBI, thought to be potentially preventable. Maybe they got a little hypotensive or hypoxic pre-hospital, but if something had been done maybe perhaps a little differently, those individuals might have survived. But really the striking statistic is the number of deaths from hemorrhage. So well over half of the potentially preventable deaths in the civilian pre-hospital environment were from bleeding. Now, surely this can't apply in the hospital. Those of you that are here who have been to LA County or trained at LA County know it's an outstanding trauma center and program. But they, in this very important paper, critically evaluated their potentially preventable deaths and found that although it was a small percentage, it wasn't zero. They found 51 deaths over the course of about 8 years. And any guesses as to what the #1 cause of death in the hospital at LA County after you've had your trauma workup and evaluation and resuscitation is bleeding. So even in the civilian world, bleeding is a major problem. Now, what about from a system standpoint? Surely we've sort of come a long ways in trauma systems. We can identify these patients that are bleeding a lot. Shock is no longer a problem, and we can deal with shock and we can resuscitate patients. Well, this paper from the Pennsylvania trauma system would say that, well, we've got some work to do there too. So These are patients that are only moderately injured, ISS of 9 to 24. And if you look at their probability of survival, if they're in shock, that's this line here, the odds has not changed at all over the course of a decade. And so these, again, are patients that really motivate me and have inspired us to apply some of these combat casualty lessons learned. Now, there are other causes of bleeding, not just trauma. We had a chance to look at this very recently, and these are the numbers for other lethal causes of hemorrhage. So if you think about ruptured AAAs, maternal pericardium hemorrhage, peptic ulcer disease, those are real problems. But proportionately speaking, trauma way outstrips them. So there are about 10,000 deaths from AAAs every year in the U.S., a little over 100 maternal deaths every year in the U.S. This is all from bleeding. Peptic ulcer disease, about 2,000. Any thoughts as to how many patients die from bleeding in the U.S. every year? 50,000. These are young, vital patients. So the other sobering statistic is the years of life lost. So nearly 2 million years of life lost from bleeding alone in the U.S. due to trauma. So this is a bit of a public health crisis and a national emergency. The National Academies of Sciences, Engineering, and Medicine, or NASEM, have put out this report very recently that's called for 0 preventable deaths. That's a pretty bold number and a challenging number to get to, but there's some legislation that's being put through to hopefully fund and support these efforts. The current bill is called Mission Zero. It's sponsored by Senator Duckworth. And here, again, are the statistics. So it's felt that approximately 1 in 5 trauma deaths are potentially preventable. And the exact numbers are being worked out by Brian Eastridge in a series of civilian studies that should be published hopefully in the next several years. If you do the math again, over 1,000 deaths in OIF and OEF over the course of a decade, 300 potentially preventable trauma deaths in the civilian realm. So what are we doing about this? Here are the action items. Just a couple quick bullet points. We need a national trauma system, some sort of integration, oversight, address this from a system standpoint. And as you all here have done so well, we need better and stronger military-civilian collaboration so that these lessons from the battlefield can be applied in the civilian domain and then refined and new innovations developed here and fed back to the military. That's how we're going to get to 0 preventable deaths. And then, of course, none of this happens without funding. We really do need to fund trauma research. So with that brief preamble, I'll talk about more specifically whole blood. What's the justification for whole blood? Has it ever been used before? Well, of course it has been. We just forgot how to do it. And hopefully we'll sort of dust off the cobwebs here and figure out how to do it again. Talk briefly about the pathophysiology of hemorrhagic shock. What the heck happened to whole blood? Where did it go? And then what about the future? So in reading about the history of resuscitation and transfusions, these 2 papers really stand out to me, and I would recommend them to you. 2 Scudder orations by giants in our field, David Hoyt and Ron Mayer. And one of the most interesting points that stood out to me was the very first blood transfusion that was performed in this country. So it was performed in 1908 by, of all people, Alexis Carrel, who won the Nobel Prize for vascular anastomoses. He was called by a fellow surgeon in New York to come attend to the surgeon's child that was bleeding. So there was this neonatal hemorrhage phenomenon. Vitamin K shots had not been discovered yet, and so neonatal hemorrhage was a real problem. This child was bleeding profusely, and it was apparent to everyone in the room that the child needed a transfusion, but they really had no means of either collecting the blood or administering the blood. So what Dr. Carrel did was he took his surgeon colleague's radial artery, anastomosed it to the popliteal vein of the child, performed the transfusion, then ligated both vessels. Both went on to survive. So you think transfusions here are a little difficult? Imagine doing that. Got to book the OR for a transfusion. So thankfully, things progressed, and we discovered bottles and tubing and how to collect and store and administer a little more straightforwardly. By the time World War I came around, these 2 individuals, they're not at all related. One, Major Robertson, was a surgeon in the Canadian Army. Captain Robertson on the right was a physician, not a surgeon, but a physician in the U.S. Army. But both participated very actively in setting up a transfusion program in World War I. Now, it's interesting, there was a lot of debate back and forth in World War I and then again in World War II about what was the best approach to resuscitate these trauma patients. So in World War I, the U.S. was very pro-transfusion. The Brits, our allies, but in this case opponents, were very pro-saline. Fast forward a few years, the tide had turned. There was this concept of wound shock, thought to be due to a toxin, advocated by Walter Buchanan. And now the U.S. was saying, no, we can do all this resuscitation stuff with just some dried plasma and albumin, it'll be fine. And the Brits were like, no, you got to give blood. And so you can see this tug of war going back and forth. Ultimately, Churchill, chair of surgery at Mass General, who deployed for over a year to the Mediterranean and North African theater, said, you guys are crazy. Everybody in the U.S. is going nuts over this wound shock. It's blood loss. Give them blood back. And it was ultimately after he sort of brought clarity and sort of simplicity to the problem that the U.S. started once again giving whole blood. So what's interesting about this whole blood is that it was not type specific. So if you look at the details of what it was they were giving stored blood. It wasn't warm, fresh, right out of the donor, but it had not been stored for very long. But it was sort of a generic, not type-specific type O whole blood. They used it, and sometimes it was fresh, other times it was shipped further forward. And what were their outcomes? So by today's standards, this is not a high-quality outcome study, but if you just read through the documentation from World War II, they gave a number of recipients who were not type O, this type O whole blood, antibodies and all. And they had actually very good outcomes. So 265 incompatible transfusions, so a type A or B or AB receiving type O. They only had 3 transfusion reactions that were deemed minor. Now, they did have one situation where a patient had some hemolysis. And after that, they actually started looking at antibody levels, so actually titering out how many anti-A and anti-B antibodies were in this donor unit, and then sort of sorted them out into low antibody levels and higher antibody levels, and then giving the non-type O recipients the ones with low levels of antibodies. And that seemed to actually work out quite well, as documented by this Thor group led by Jim Stubbs at Mayo Clinic. All right, so fast forward to Korea and Vietnam. Of course, we haven't developed a blood fractionation yet, and so whole blood is still being given. And what was being given? Again, stored type O whole blood. Actually, it was shipped over from the US to Korea. And they continued this method of sorting out the units into low and high titers. They would give the low titers to the type A's, B's, and AB's, and the high titers to your type O recipients. And then if you look at the outcomes, they gave over 400,000 or approximately 400,000 transfusions, and there were no reported reactions. Now, maybe they didn't keep great records, but nonetheless, there were no reported transfusion reactions. Now, again, there had been some advances leading up to Vietnam, and things were a little bit different. They actually shipped all types of whole blood, not just type O. They sent type A, AB, B, but in the forward locations where it was difficult to sort of do the blood typing and that sort of stuff, so meaning like out on the Ho Chi Minh Trail or in the middle of the jungle, they would give type O, but they would give type-specific whole blood elsewhere. It's recorded that there were over 230,000 whole blood transfusions given in Vietnam with a very low percentage of transfusion reactions, like 0.01%. So it appears that with hundreds of thousands of type O and some type-specific whole blood units being given since 1915, it seems to be pretty safe. Now, we'll talk in a little bit about what the heck happened to whole blood. First, I just want to review the pathophysiology of hemorrhagic shock. So this is the bloody vicious triangle, the FACS fast-forward, self-feeding propagation of death that leads to poor outcomes in our trauma patients, the hypothermia, coagulopathy, and acidosis. It starts with blood loss. So you're simply losing red cells, clotting factors, and platelets. In that process, the endothelium gets activated, the glycocalyx starts to shed, you get autoheparinization, you get activation of protein C, you get mobilization of TPA, leading to this coagulopathy. Ultimately, it has some adaptive functions. You don't want the rest of the body to clot off while dealing with a local problem. So you have local hypercoagulability, but systemic hypocoagulability. But at some point, it becomes maladaptive. And then you add in these iatrogenic factors of pumping in cold saline or even cold blood products, hemodiluting by giving saline and non-blood product type infusions, and then not recognizing that the patient is in shock or delaying in some way the resuscitation. Now, whole blood really would address all of these. So it would address the blood loss, it would address some of the systemic factors. We know that the plasma is really therapeutic to the glycocalyx and can lead to restoration of it. And of the iatrogenic factors, really it addresses the dilution. Now, if you don't hook the whole blood up to a warmer, it's going to be cold if it's been stored. And then there's really not much that whole blood is going to do if you don't recognize that the patient is in shock. But all that is to say that whole blood really does directly address most of the pathophysiologic elements of hemorrhagic shock. So it's good stuff. But if it's so good, why haven't we been using it for the last 40 years? What happened to it? Well, there are some challenges logistically with collecting and storing it and giving it. But I want to highlight those as well as some of the military solutions and then how we can translate that into civilian practice. So I really like the far side. I sometimes feel like Edgar here. Moments before he was ripped to shreds, Edgar vaguely recalled having seen that same obnoxious tie earlier in the day where he was being sold a bill of goods. Oh yes, I guarantee these bullets are pure silver. So if this is your friendly trauma surgeon fighting hemorrhage, I wonder if instead of silver bullets, these bullets are blood components, and the blood bankers have been selling us a bill of goods. Now, if you don't like the far side, some of you may be foodies. You can think of these blood components as sort of deconstructed spaghetti here. Probably not a great idea, and it tastes better when it's all together. Sometimes, another analogy I've heard is that the blood bankers are sort of like car salesmen, but they don't want to sell you the whole car. They sell you parts of the car here and there, and then it's your job to put it all together. So I think of it as sort of the holy grail in resuscitation, especially for the exsanguinated trauma patient. But what happened? So the AABB, sort of like, it's the American Association of Blood Banks, but they don't like to be called that. They like the AABB, sort of like Prince, it was a symbol after a while. So it's the AABB. They are like the Joint Commission or the Committee on Trauma for blood banks. So they really are responsible for certifying and validating that you're following safe practices. And they are largely responsible for many of the advances in blood banking. Unfortunately for our trauma patients, some of those advances have maybe been detrimental, and thinking back to our bullet salesman there, maybe not the best thing. So what are some of the problems logistically? So maintaining a blood inventory of all these different blood types is a challenge. Storing it, if you really want to give the gold standard, the fresh stuff, it's a little hard to store, and it tends to sort of like get contaminated with bacteria and maybe sort of degrades in quality over time. And then availability. Most of these patients don't come in mid-morning, although in Philadelphia often we get GSWs at 10 in the morning, unfortunately. They often come in at 3 a.m. And so, the blood bank isn't necessarily ready to go with warm, fresh whole blood at 3 a.m. And then what about safety? We talked about the type mismatching. There was a lot of concern over many years that it was not safe to give, quote, universal whole blood because of the antibodies even in type O. What about disease transmission? Are we going to give our patients hepatitis or some unknown entity that we haven't even discovered yet? And then graft versus host disease and some other sort of nuanced things the blood bankers worry about much more than I do. And then, is there really a need for whole blood? If you've got a medical patient that's just a little thrombocytopenic and you want to make him or her euboxic, you don't need to give all the whole blood just to bring the platelets up. So great, fractionation really does address those sorts of patients that just are a little anemic, or maybe you have a patient that's a little thrombocytopenic, as I mentioned, or a hemophiliac. You don't need to give those individuals whole blood. So really these fractionation advances have addressed some of those problems, but again, maybe not ideal for our trauma patients. And then just brief mention of this paper, misinterpretation and misapplication of these findings led to what I call the crystalloid and coagulopathy era of over-resuscitation and not giving blood products to match the crystalloid that we were giving. I'd really commend this as a great historic article for your consideration. Now coming full circle, how we address some of these challenges? Well, again, in the Crucible of War, we figured out, well, maybe these patients need some procoagulant function of plasma and platelets. And then the Borgman article came out advocating for a high ratio of these procoagulant functions that resulted in a dramatic improvement in mortality. And so more plasma and platelets are good up to a point, and that point is still debated. We looked at this for East and put this into a practice management guideline and found that, lo and behold, survival is improved if you have a high ratio of plasma and or platelets to red cells, and gave it a strong recommendation for your massive resuscitation or transfusion protocols to build this in to the logistics of the protocol. Now, is there a better way to achieve this ratio? Mirabile dictu, whole blood, gets you a pretty good ratio of blood products. So this is an interesting thought experiment. If you just do the math and add up these different units, if you have 1 to 1 to 1 and some cryo, here's what you get. You get 680 cc's and a truckload of anticoagulant, citrate. It really starts to add up. It's relatively anemic. The coagulation percentage is not great. The platelet count is so-so. A little bit of fibrinogen in there, so that's good. But compare that to whole blood. You get 500 cc's, so a pretty compact, high-powered unit here that's not anemic. It's got 100% of the coagulation activity. Platelet count is mighty good. Fibrinogen, same amount, but very little citrate, relatively speaking. So in order to get what you're giving in terms of red cells, clotting factors, and platelets, using components, you'd have to give a unit of red cells, 2 of plasma, 2 of platelets, and by doing that, you would then double your volume, and you'd be giving just a mountain of citrate. So really difficult to sort of reconstruct this deconstructed whole blood unit. Much better to just start with the whole blood and give it that way. And Phil Spinella showed this very convincingly in our trauma combat population. This is, again, warm, fresh whole blood, so a little different from what we're talking about in the civilian realm. He compared 100 whole blood patients that was given type-specific and, again, warm and fresh to 250 component therapy controls. And here's what he found. The volume of blood products was less in the whole blood group. The amount of citrate and additives, the preservatives, the anticoagulants in your blood, much less in the whole blood group, and survival dramatically better in the whole blood group. So really this is pretty compelling. And for those of you who have deployed and been involved in one of these whole blood drives, really if you look carefully at that bag, it says whole blood, but really it's supposed to say gold. It's really liquid gold. It's so amazing. It's great stuff. Now, how do we apply this in a civilian setting? It's not easy, and that's why it hasn't been done universally across the country or across the globe. So there are challenges with blood typing and the logistics that I talked about, screening the blood for diseases, storing it, and then some questions about treating it. Do you zap it with radiation? Do you filter it to make it more safe? So ideally, the product that we would want to give all of our bleeding patients would be type-specific. It would be pre-screened or from pre-screened donors. It would be warm, fresh, with all the clotting factor activity still preserved. And you would filter out some of the white cells or all the white cells that may have some detrimental effect, may carry diseases, may incite inflammation, You might want to also irradiate it to sort of disable those white cells. Now, the question is there something that's sort of adequate? You know, an 80 or 90% solution that's better than component therapy. It has not been deconstructed. Well, that's where the question of, quote, universal whole blood comes in. Is there a way to sort of have, you know, a donor pool that undergoes the standard screening? If we store this blood for a while, this whole blood, will it still function after a few days? And then, is it okay to sort of bypass some of these more onerous treatments? Now, it's interesting, the military is often accused of having short-term memory loss. And I would say that in this case of whole blood, we really have had short-term memory loss. We forgot that in World War I, II, Korea, and Vietnam, we were using, in many cases, type O whole blood to non-type O recipients. Now, if you look at this Emergency War Surgery Handbook, which is really the doctrine that most deploying physicians follow, as well as the CPGs, it says exactly this. If fresh whole blood is required, it must be ABO type specific. That you just added in a huge logistical challenge for our civilian colleagues. And then if you look at this First to Cut by Brian Eastridge, one of the case scenarios is about a whole blood mismatch. And they say that there's no universal donor for whole blood, meaning you give type O, you're going to be given a bunch of antibodies. And a donation should be type specific. Is that really true? Well, we saw from all those historic examples back in earlier in the 1900s that was not necessarily true. So is it possible to have a universal whole blood sitting in our trauma bay refrigerators? Well, if you look at the demographics of blood types, you want to pick a blood type that's common and is going to be as safe as possible. So here's the breakdown. Type A, about 40% of our population, B, 10%, AB, 5%, and then type O, 45%. So right away, just based on that alone, you would not pick AB donors. Then if you start looking at these others, you know, they've got antigens, so the cells are probably going to lyse, and they've got antibodies, so probably not ideal to pick either A or B as your donor. So you're left with type O. But you've got these antibodies. So what's going to happen when you give it to non-O recipients? It turns out that, yes, antibody levels, as we've already said, do vary. And it is possible to identify donors with very low levels of A and B antibodies. So taking that experience as well as the lessons learned from platelet transfusions, which are often non-type specific, which was news to me. I thought all platelets were type specific, but it turns out often they're given sort of universally. It really is possible to have a universal whole blood. What about storage and treatment? So all of you know that platelets are stored at room temperature currently, which is interesting. The reason being, so they accept a 5-day storage shelf life in favor of the platelet count staying elevated for a longer period of time. Does that really matter in our trauma patients that are bleeding out on the floor? Probably not. You want functional platelets, and it turns out that cold stored platelets are more functional than the warm stuff sitting on the bench. So a group in San Antonio, and Dr. Spinella and others have looked at this, and lo and behold, cold platelets function better. So that's a positive. What about these other treatments, the radiation, the filtering? Is that really necessary? Well, if you look at the Mayo Clinic experience, they decided that radiating the white cells to get rid of them was probably too cumbersome and not really all that necessary. And there's still some questions about platelet filtering or white cell filtering. Can you filter out the white cells but leave the platelets? We think so. There's one filter by Terumo that proposes to do that. But it's a little concerning in that it seems that those platelets that are left behind may not be as functional as we'd like them to be. So if we had our druthers, the ideal product would be type O, cold stored to sort of deal with these logistical challenges. And we think it can be safely stored for up to 15 days. From a safety standpoint, we pick our low titer product. We do standard donor screening. We don't irradiate. And as I mentioned, there's still some question about the leukoreduction filter. The question now remains, is this truly safe and is it effective? So looking forward to the future, there have been some recent publications that I'll highlight, and then the punchline is the new AABB standards. So this is a paper by Brian Cotton, really outstanding presentation at the American Surgical several years ago, randomized study looking at whole blood versus components. Now this was type-specific whole blood, but it was filtered, so there were some questions about the platelets. So what they did in this case is that they actually administered the whole blood patients supplemental platelets. They had 52 in the whole blood group, rather 55 in the whole blood group, 52 in the component group, and on their intention to treat analysis, there was really no difference in this, in what they called this pilot study. But if you take out the TBI patients and start to drill down to those that are truly bleeding to death, it seems that the whole blood group did receive fewer red cells, less plasma, and fewer total blood products. So it's probably by giving this even modified whole blood component or product, resuscitation fluid, you are doing some good to these bleeding patients. Mark Yazer at Pittsburgh and his colleagues there looked at their experience with whole blood a couple years later, so this is now quite recent. What they did is they used now not type specific, but this quote universal type O low titer whole blood. They would give up to 2 units in the trauma bay. They only took it from male donors. They did store it for up to 10 days, and then focus on male recipients to avoid seroconversion from the whether if they were giving type O positive, and then pick patients that were acute bleeding, angry Brian Cotton, the ABC score, which is hypotension, tachycardia, positive fast, and penetrating mechanism. Any patient with 2 of those, they would enroll in their study. And so they compared 47 whole blood patients to 145 historic controls and found that in fact the whole blood group received more product, but they were able to achieve a higher ratio. There were no safety issues, but this study was underpowered for any sort of mortality assessment. So just this January at East, there was an abstract by the group at Cooper, so John Porter and Charlene up there in the top corner. Their protocol has been rather similar to the Pittsburgh protocol, and this is really the protocol that we've adopted. So 2 units of low titer type O whole blood from male donors, stored now up to 2 weeks, focusing on male recipients, those that are hypotensive, obvious source of bleeding, but excluding the TBI and patients that come in cardiac arrest. So they've now had 14 whole blood patients at Cooper. They compared that to 14 component therapy historic controls, and in contrast to the Pittsburgh findings, they actually found, similar to Houston, that they gave less packed red blood cells, and then in fact their whole blood patients had a shorter ICU length of stay. And again, small study, so no difference in survival. So lastly, we've adapted this at Penn. This is our blood refrigerator in the trauma bay. You can see whole blood is an option. Now what's interesting about this product is that if you look at it, it's sort of pale up top. It looks almost like plasma. So that's because the cells start to settle. But as you pull it out of the pack and jiggle it around a little bit and hang it, it sort of mixes around. So our protocol is very similar to Cooper, but we have 4 units in the trauma bay, and we give our patients that receive whole blood up to 4 units, and we keep 2 in reserve in the blood bank. We focus on, we don't see pediatric patients, they all go to CHOP, focus on male donors and females outside the childbearing age range. ABC score, again, is our trigger, and if you're giving blood in the trauma bay, you really should think about giving whole blood first. And we exclude the TBI and the ED thoracotomy patients. So we went live with this in October, and we've now had 14 patients. It's about 1% of our activations. And it's interesting, our mismatched transfusion rate follows the demographics of the blood types. So we've had 54% mismatch, so type O going to non-type O patients. But we've had no hemolysis, we tracked this very carefully, and almost an 80% survival. And that compares favorably to the Cotton results of 73% and the Pittsburgh Yazer results at 64. So the Aabb Standards, so again, this is the group that really regulates your blood bank. Press release, just in January, big news. They are going to make this type O, quote, universal whole blood available, so that your blood bank can decide, if they so choose, in collaboration with your blood supplier, to start to stock, store, and infuse whole blood. So this is officially coming out in April, not that far down the road, but what this means is that you don't have to apply to the AABB to get an exception to policy to give whole blood. So in summary, bleeding is a real problem. 50,000 trauma deaths and 2 million years of life lost in the U.S. annually from trauma bleeding alone. It's the #1 cause of both pre-hospital and in-hospital death, of both military and civilian. I really believe that whole blood directly addresses the pathophysiology here, and ongoing research will tell us if this is the right thing to do, but now it's going to be more widely available, and so hopefully those results will come out more quickly. So just in closing, one of my good buddies from deployment, Cabot Murdoch, used to always ask me, what are you doing to stop this patient's bleeding? So I would say, well, I've got my hands in the admin here. Cabot, what are you doing with your hands? And I'm giving whole blood. All right. So with that, I really thank you for the opportunity and welcome any questions.
That was great, and I think we have time for questions. Very provocative for not just our trauma patients, but many of our patients who have big blood loss issues, vascular cancer.
I enjoyed your talk enormously. I particularly enjoyed your attention to the history of where we've been and where we're going. There was one piece I can add, and maybe Dr. Cantor can add with a bit of lore. Alexander Brunschwig, who taught us how to do pelvic excineration, generated enormous bleeding. His results were good. His survival rates were excellent. And one of the reasons was that he had a colleague who worked with him by the name of Virginia Pierce at Memorial Sloan Kettering Cancer Center. And the issue was rapid infusion of blood products. You showed that ETO picture with the bottled blood. Well, somebody had to invent the plastic bag, and it's used as a rapid infusing system that could be squeezed, etc. And she invented that and convinced the American Association of Blood Banks that despite their skepticism, it was worthwhile. The way she did it was she invited them all to her home. And they were saying, oh, this plastic thing won't be strong enough to do what you aim to do with it. So she took them out back, threw a bag of blood over the house, and then went to the other side. The bag was intact, and they said, oh, this is the...
Dr. Hundal. Oh, okay, see.
Yeah, so really important comment and question. So TBI, of course, is part and parcel of especially the blunt polytrauma patient. We're looking for obvious severe TBI. So for our gunshot wound victims, brain on the bed, trauma arrest, or a dilated, herniated unilateral pupil with obvious external signs of trauma to the brain. But I would say going forward, as this product is more widely available, it would be reasonable to consider giving it to some patients that you think are survivable. And it's interesting, the Cooper experience early on, they had a patient that was thought to have TBI, but it turns out their neurologic changes were all from shock. And that patient really should have been given whole blood. So I think we can start to relax that, as well as the female recipient criteria. Why not just give them a little ROGAM if it happens to be an O positive unit? We've got treatments for this, and those are survivorship problems. So really good question. Yes?
I really enjoyed your talk. Great data, great history, and interesting topic. What struck me towards the end is, your early experience and the guidelines surrounding giving whole blood. And, these are patients who are taking massive transfusion. They're not going to be able to consent to different things. So, males greater than 18, women greater than 50. So there's a huge fraction of women who aren't going to benefit from this survival, get a survival benefit. How do you see this playing out from a population standpoint? Are, let's say, younger women who are past their childbearing, they don't want any more kids, are they going to have to carry a card around or wear a bracelet? How is that going to play out? Because there's missed opportunity there. Because there's plenty of women under 50 who are done having children or not going to have them. How's that going to work?
Our objective really was to sort of get the foot in the door and get this ball rolling with the AABB, starting to get them on board as advocates and allies rather than opponents. And then once we get the progress towards yes, then start to broaden the indication. So absolutely, I think it is critical that we are able to give this to children, to women, and I think there are solutions such as giving empiric ROGAM, or your blood type that you're giving your blood, or if you don't, your blood bank does. Just identify those patients that need some after treatment. So really, I think there are solutions. We just have to sort of get the ball rolling here first. Yes, sir.
One of the many contributions that Stanley Crawford had at the Methodist when he was operating on aortic surgery, thoracic abdominal aneurysm, was that him and an engineer from the Methodist developed this rapid reinfuser machine, which was connected to the cell saver. And when he had an enormous amount of blood loss, he would then clamp the circuit so that it would then, the blood would be reinfused, whole blood, the patient's losing directly into the patient through a large bore cannula in the neck. Has that been applied? Obviously not in the field, but maybe when the patient hits the hospital and you have an enormous amount of blood losses in trauma, where you can do that?
I'd say to some degree we have a reinfuser system on our Plurivax, but when you look at that blood, it's a little coagulopathic and maybe not ideal. Some of the red cells are lysed or injured or damaged. So I would say it is possible, probably more practical in the operating room, where it's literally pouring out into the field and then almost directly going back into the patient, as opposed to exsanguinating into the chest, percolating there for 45 minutes. Then you're going through the trauma. We heard about all the complications from the chest tubes, going through the trauma of a chest tube, then into the Plurivac, and then incubating there for a while, and then back to the patient. So I think it could be combined with a cell saver, and perhaps we could one-up the cell saver.
I think it makes, personally I've used it, and with ruptured aneurysm or big thoracic abdominal where you have a lot of bleeding, it really does make a huge difference.
That's a great point.
Giving whole blood, the patient's own blood, because you're giving it as soon as the patient's shedding it.
Even better than donated blood. Yeah, it's something to look into for sure. Great, thank you.
Okay.
Thanks for your talk. I think this has the potential to really simplify the weight-based resuscitations necessary for pediatric trauma. In light of your new paper and stuff, I was wondering if you could tell us what you're telling your anesthesiologist or ER nurse if you still got component therapy available, not whole blood, to give to children during massive transfusions.
So in the trauma OR, we are not giving whole blood yet, but again, it really does have the potential to simplify things. And so one of those expanded indications, I think, will be to move it out of the trauma bay, not just give it first and then shift to components, but give it until you know the patient's blood type, really, or get control of the bleeding. In pediatrics, it's interesting, pediatric cardiac surgery has been sort of the last vestige of whole blood use in this country. And so we've sort of piggybacked off of the Red Cross's experience with preparing units of whole blood for cases at CHOP to use some of that as our supply for the whole blood. So I would say it absolutely simplifies things, but in kids you still do have to do things like draw it up as an aliquot in a syringe, and sometimes maybe hand infuse it or hook it to a syringe infusion pump. So I think it does have potential. We've not done it in Philadelphia yet, but it's perhaps low-hanging fruit.
Dr. Trotman, last question.
Well, it's interesting as a non-trauma surgeon to sit here to see that at least in the civilian world, whole blood is really struggling in the trials to demonstrate superiority. In wondering what your perspective, being very familiar with the field on that is. Could obviously the statistical underpowering could be that from a purely intellectual standpoint is actually not better. That's a possibility of much too. But one thing that hasn't come full circle really is the control groups. In World War II or a long time ago, it was whole blood versus saline or versus acute red blood cells. Nowadays, when you go with more rigorous, and more modern control groups, which are the higher ratio of blood products to red cells control, could it be that there is actually not that much difference after all and giving a high ratio of components? What's your perspective on that?
Absolutely, I think you have to. I think you do have to maintain that as a possibility, and in fact, perhaps a probability that as with many things in medicine, we sort of work towards the mean, and now all of a sudden our groups are so similar we can't find a difference. I would say one thing that sort of gives me some hope that we'll find an improvement with the whole blood. Actually, two things: logistics. So much easier to maintain that ratio with your whole blood, and secondly, the preservative that's in there. So we've found with our component therapy wide swings in calcium, for example, magnesium as well. And I've had a patient personally that had an unnecessary cardiac arrest from profound hypocalcemia, probably related to citrate toxicity because patients in shock don't metabolize it quickly enough. So I think giving less citrate is probably a good thing. But will we find a compelling difference, a survival outcome like Spinella did? I don't know, and that's why it needs to be looked at carefully. Very good.
One last question. Oh.
Mainly a comment. There are several studies that have been done, especially with pediatric cardiology, comparing component therapy versus whole blood, and the data supports fresh whole blood and has for years. We have probably 20 to 30 years worth of data supporting fresh whole blood.
Just randomized the data?
Yeah, basically CHOP is the main one that started it back with Bill Norwood.
Very good.
Yes.
All right. Well, thank you again. It's really a pleasure to have you.